Brain and CT Chest in the Critical Care Medicine Module 2. We are honored to have with us today an esteemed speaker, Dr. J.S.K. Chaitanya. Before we begin, I would like to take a moment to introduce him. Dr. J.S.K. Chaitanya is a distinguished expert in critical care medicine. He did his MBBS from Gundu Medical College, Andhra Pradesh, and DNB in General Medicine from Kovai Medical Center, Coimbatore. Dr. Chaitanya has successfully completed its IDCCM and EDCIM from esteemed institutions. Dr. Chaitanya currently serves as the head of the Department of Critical Care at KIMS Gachibowli, Hyderabad. In addition to its expertise in critical care medicine, Sir specializes in neurocritical care and the management of neurological emergencies, making him a distinguished expert in the field. As a clinical pharmacist, having thorough understanding of the significance of MRI brain and CT chest is essential. In today's session, Sir will provide a valuable insight on this topic. I now invite Sir to expertise its knowledges. So over to you, Sir.
Yeah, thanks for the kind introduction. I think 2 weeks ago we had our first session on X-rays and CT brain. Today I think we'll go forward because these are little advanced modalities of imaging where there is a purpose in why we need to go on to have a more advanced imaging modality. I suppose my screen is visible to everyone.
Yes.
Yes. So first, let us go through chest CT. I prepared this talk with an understanding that my last talk was on X-ray and CT brain. So basic anatomy, most of you should have been, with that understanding that you all have listened to my previous talk. I'll not go deep into the previous talks, which were repeating the other ones. Okay, so why CT chest? As we all know, X-ray, as we saw last time, it is a 2D image. It's a two-dimensional image. It gives limited detail of the soft tissue and the vascular structures. There is a chance that we can miss small lesions or small nodules. We can only see outlines of the mediastinum and roughly estimate the structures which form borders of the mediastinum, but then we can't get a clear view of what's happening within the mediastinum. It is less accurate in complex cases, but advantages are it can be done with a very low radiation exposure, and it can be done at the bedside. So the ease of doing is so high. That's the reason why we depend more on X-ray chest. But CT chest, the other hand, gives us 3D cross-sectional images. It gives a better visualization of the soft tissues. Smaller lesions can't be missed. We can pick up lesions in very early stages. We can get a detailed imaging of the mediastinum. And when added up with a contrast imaging, we can get more information about pleura, vascular structures, infectious pathology, all these things. We can improve our diagnostic accuracy, and at the same time, we can get clear visualization of the skeletal structures as well. It can be also used for our surgical planning because of the help of 3D reconstruction. So before I go through, so this is a chest X-ray where, as I discussed, we can see bones, we can see the lung parenchyma, we can see the mediastinal structure, especially the upper mediastinum formed by the aortic arch, the lower mediastinum, the left border formed by the ventricles, right border formed by the right atrium. So we were discussing all these borders. So when we go into CT, when we are able to get axial images, let us discuss first through the first 4 or 5 slides. I'll walk you through what structures we'll come across at different levels of imaging. So these red lines are the markers at what level the image which I am showing you is being displayed. So the first slice, the first axial section, when we see an image at the level of great vessels. Great vessels is as seen on an X-ray. When we look at that place, what we identify is we'll be identifying trachea and we'll be identifying left and right subclavian arteries. Behind trachea, we'll be identifying the esophagus, then subclavian arteries, and skeletal structures like ribs, sternum, scapular bones. And we'll be also able to see the apical segments of the both the lungs. Coming down, when we browse through the axial sections, we'll first come across the aortic arch and adjacent to it, the superior vena cava. When we go further caudally, as we approach the carena, that's where the trachea divides into both the right and left bronchus, we'll be able to see the major vessels like the ascending aorta and the descending aorta. We'll be able to see the bifurcation of the trachea. We'll be able to see the pulmonary trunk and the right and left pulmonary arteries. Further down, we'll be able to see the atrial at the atrial level. We'll further identify structures opening into the right heart, like the superior vena cava, the right atrium, left atrium, and further down, we'll be able to see the ventricles. At this level, we'll be also able to see something in the mediastinum, like the heart, whether it is dilated or not. How is the pericardium? How is the pericardial space? Is there any fluid there? How are the lung parenchymas, posterior lower lobes, the domes of the diaphragm? So all these things come up when we go further down. So what CT chest can information what CT chest can give us? Like we can evaluate in terms of any parenchymal pathologies. We can evaluate in terms of airway pathologies like foreign bodies, tracheomalacia, tracheal stenosis. We can look at the skeletal structures like bones, bony pathologies, fractures, muscular problems like abscesses, breast evaluation. All these things can be done. As I said, parenchymal, airway, and skeletal predominantly can be evaluated by just doing a plain CT scan. But when you give contrast, we can get additional information of the vascular structures, like if you are searching for a pulmonary embolism, if you are evaluating a patient for a hemoptysis, so it's come with blood in the cough, where if there are any bronchial arteries involved, if you are looking at somebody who is having a empyema, to look or any patient who has pleural effusion to see if there is an infectious etiology to it or a malignant etiology to it, then to study the pleural structures in detail, or sometimes to understand the mediastinal pathologies, where you have to delineate the structures in the mediastinum, whether they are vascular or not, and to understand their anatomy more in detail in relation to the vascular structures. A contrast study will add on, giving us more clear information. So I'll just browse you through few images and try to explain how the imaging is going to guide us. So first, I'll walk you through few parenchymal images. This is what is most often encountered, and the patho and the clinical pharmacists have predominant work in the ICU is to understand based on what decisions are being taken. So this diagram here shows you the functional unit in the lung pertaining to an imaging modality. So we all know the airway divides down over the generations to form terminal bronchioles, which ultimately open into alveoli, forming alveolar sacs. This is where the real blood oxygen transfer happens from the alveoli into the blood. So this one terminal bronchiole, along with its blood supply, the centrilobular artery, with the supply with the alveolar sacs which are being supplied by these structures form a secondary lobule. The surrounding tissue or the surrounding interstitium, which is carrying, which has the lymphatics and the blood vessels which carry pure oxygenated blood from these alveolar sacs, form the boundaries of this secondary lobule. So by looking at these changes or looking at these structures and to identify where the pathology starts will give us a guidance on where what sort of pathology it is. It's an infection, it is a cardiac origin, it is a malignant origin, or the inflammatory process, where is it happening in the airway or in the parenchyma or in the interstitium. Based on these structures which are involved, we'll get an idea. So in the right image, you can see as I said, so this particular part which I am trying to highlight is our terminal bronchiole. The blood vessel which is in the blue color is the centrilobular artery, which is bringing in the blood without oxygen. This blood vessels surrounding the alveolar sacs and the air through the alveolar sacs tries to perfuse into the blood, into the interstitium where our arteries which carry oxygenated blood are present. So these form the interstitium. The yellow line forms the interstitium. So based on the structures involved, as I said, and based on the dominant pattern, how the lung is being involved, we classify and we try to differentiate or narrow down our diagnosis, what sort of disease is causing this sort of changes. So in HRCT, what we find is either a reticular or nodular pattern in the interstitium. Here you can see the small diagram here on the right is showing you a smooth thickening of the interstitium, or sometimes there can be nodular thickening of the interstitium. There can be high attenuation areas or low attenuation areas. You can see if low attenuation areas is where the image looks more blacker. So this happens usually when there is emphysema or cysts in the lung. High attenuation is when the lung parenchyma looks more whiter or more hyperdense. So it happens usually in case of ground glassing or consolidation, what we call. And then whether the etiology is happening around the centrilobular vessels or around the perilymphatic interstitium, whether it is happening more in the upper lobe or lower lobe, whether it is happening more peripherally or centrally towards the hilum. Based on all these factors, we try to narrow down our diagnosis or looking at the etiology. So the most common thing which you all have been hearing from the time of COVID is ground glassing. The moment we get a CT, we hear often in the rounds that there is significant ground glassing. So what does that ground glassing mean? So ground glassing is opacification of our secondary lobule, obscuring the bronchial, not obscuring the bronchial vessels. So as I said, the secondary lobule has the alveolar sacs, which are usually air-filled. At the center, we have a airway, the terminal bronchiole, and the blood-carrying vessels, the centrilobular artery. When this alveolar space, which is normally filled with air, starts getting filled up with secretions or blood or any other fluid, what happens is there will be opacification of the secondary lobule. Instead of looking black as I'm pointing, it starts looking white. When this haziness doesn't obscure your blood vessels, then we call it as ground glassing. As you can see here, this is what is ground glassing. But if the opacification is so dense that even the blood vessels are opacified and you will be able to see only a airway in it with air as this. So this is what we are seeing here. This is called consolidation. The characteristic finding what we are having is called as air bronchogram, where the airway is clearly seen surrounded by a wide dense structures, or which normally has to be black, is all opacified. So this is called ground glassing or consolidation. So based on this, whether these findings have turned up acutely or chronic, whether they are predominantly in upper lobe or lower lobe, we have various differential diagnoses. From the clinical pharmacist point of view, things which we can definitely know, which we need to know are whether this ground glassing is suggestive of an infectious etiology or not. How do we know that? If we are seeing it, these changes restricted to one single lobe, if there is dense consolidation, we need to think of something called, which is infectious. If it is symmetrical everywhere, then we need to think of etiologies other than infection or viral etiologies. Other than infection, most commonly would be cardiac, like pulmonary edema. When we see patchy infiltrates in diffusely in both multiple lobes of the lungs, then we need to think of some viral etiologies or atypical pneumonias like mycoplasma and PCP and all. If these are chronic, and sometimes chronic lesions, if they are predominantly affecting the upper lobes, we need to think of diagnosis like sarcoidosis or hypersensitive pneumonitis. If it is involved everywhere, then we need to think of alveolar proteinosis, where the proteinaceous material gets filled up in the alveolar sacs and then gives a picture of ground glassing. As I said in the previous image, which I showed you, where the interstitium gets thickened, either it forms reticular sign or a nodular thickening. When this increases, what happens? Fibrosis sets in, and this interstitium gets fibrosed, trapping air within these interstitial thickening lines, causing a phenomenon called honeycombing pattern. Honeycombing pattern usually signifies that there is a lot of inflammatory changes happening in the interstitium and some fibrosis which has set in. Like we see here, there is significant honeycombing in this image. And in this, we see areas of hypoattenuation called cystic changes or cystic space within the lung. This is a picture of a interstitial lung disease, which is of a little advanced stage. The next most common things which we see in an ICU are pleural effusions. Then X-ray, when CT can help in differentiating pleural effusions is when we have lockulated effusions, when we have significant posterior lockulations, those patients who are in ICU where we get bedside X-rays, where posterior structures may not be very visible to us. In such cases, a CT definitely helps here. Here you can see a lockulated effusion. We can see fluid not following the gravitational forces. We see fluid accumulating in two different chambers, compressing the lung structures. So when we see lockulated effusion, we need to think of infection. So here, what else would have helped is if we have done a contrast imaging, then we'll get to know what is the status of the pleura. As I'm marking here, we'll get to know what is the status of pleura. So pleural effusion, how does it appear on an X-ray? On an X-ray, it shows up like a opacification, blunting of costophrenic angles. Here, while in CT, when we are doing an axial CT, instead of airspace, which is usually black, we see some hypodense material around the lung parenchyma, but within the rib cage. So this helps us in identifying pleural effusion. In this image, we are seeing extensive hypoattenuation. Extensive hypoattenuation without any bronchovascular markings. This is a young guy who came to us following trauma. So this indicates there is extensive pneumothorax. And you can see these black spaces extending into the soft tissue as well. This indicates there is surgical emphysema. And you will also be able to identify two tubes here. So for somebody who has pneumothorax with chest drains in place, but still has persisting pneumothorax, we need to think of active air leak, which warrants further evaluation to identify the cause of the air leak. So CTs help in all these modalities. So this is an contrast image of a patient, which is showing I will try to explain you the anatomy as well. See, this section is taken at the level just beyond carina. So you can see the the left main bronchus and the right main bronchus. At this place, we are seeing ascending aorta and the descending aorta. And the other structure which we are seeing is the main pulmonary trunk arising and giving rise to the right pulmonary artery. And the hypodensity within the artery means there is a filling defect. You can see the pulmonary artery arising, which is showing white contrast opacification. But as it evaluates, as it grows to arising, giving rise to the right pulmonary artery, we see a filling defect. This indicates it's a pulmonary embolism. So when you see pulmonary embolisms, immediately we need to look at the etiology. Where is the source of this embolus? Is the patient having deep vein thrombosis? Has he been hospitalized? Has he been on anticoagulation or not? All these comes into that thought process. And there are more to looking into lung parenchymal changes, but I have restricted my talk to predominantly what we get to see on day-to-day basis at the bedside in the ICUs. And for clinical pharmacist perspective of view, I added 2 or 3 more slides, which you might find interesting. So this is one CT where we are seeing reticular opacities in the diffusely, bilaterally, little towards the hilum. You can see nodular pattern as well with some ground glassing. This is a case of rituximab-induced lung injury. We should always know, based on drug history, whenever a patient gets some imaging done, we need to think if there are any side effects pertaining to the medications as well. So this is one such situation. And common drugs which we need to see are such drugs like rituximab. And the next one, which I show, is of immune checkpoint inhibitor related pneumonitis, which is more common nowadays with increasing use of immune checkpoint inhibitors and what do you call immunotherapy. There is increasing instance of these conditions where usually we first try to get thinking after chemotherapy or after immunotherapy, we think of an infection, but we need to keep somewhere in our mind if this etiology is also being the cause. Here we can see nodular opacities bilaterally, diffusely. So nivolumab is the drug in this patient who presented with gradual onset worsening breathing difficulty within 2 weeks after initiating nivolumab. Another drug, which is another two drugs which we commonly come across in patients who come to ICU, which I'm leaving it as a homework for you all, is to look at methotrexate, how methotrexate can affect the lung, and the other drug is amiodarone. So these are all commonly used drugs nowadays: methotrexate, amiodarone, rituximab, and if somebody is into the onco department, immune checkpoint inhibitors. All these things are causing pathological changes in the lungs, and only if we have an eye for them, we'll be able to find such things. So I'll proceed on to MRI brain. Uh, So last week we had a discussion on CT, and I've just gone through how to look at the anatomy, what structures are there, at how do we identify those structures. For a clinical pharmacist point of view, I'd like to tell MRI is gaining popularity over the last decade because in management of acute stroke, as we say, time is brain, and the treatment modalities depend on time of onset of stroke. So we need to see what are we achieving. By saying time is brain, we are trying to salvage as much brain as possible from the brunt of lack of blood supply. We are trying to reperfuse the brain with an intention that recovering blood supply will recover the brain. So to identify whether the brain is in a state to recover or not, we need to know what's happening in the brain by understanding the physiology. So CT scan will show the changes only little late. To identify an acute stroke, MRI is the modality which can pick up the most earliest changes after an acute stroke. So MRI, unlike CT, is not a single sequence. MRI has multiple sequences to analyze what's happening within the brain parenchyma. So you would have heard from your ICU rounds, T1 image, T2 image. There is something called flare image, diffusion weight images, contrast enhanced images, MR angio. So let me briefly explain you all this. I may not be going deep into the physics of how an MRI images are treated, but then the basic principle, how MRI works, I'll just walk you through. So if you all have gone to an MRI room, you'll be seeing a very heavy machine where you are not allowed to wear any metal objects because MRI is, there is a very high magnetic field through which the patient is made to lie down. Once you are on the gantry, on the bed on an MRI table, you will be covered with another plastic mesh sort of thing, which are called as RF coils. So what do these RF coils do? The moment you are on an MRI table inside the magnetic field, all the hydrogen ions try to align according to the magnetic field. These RF coils which are placed over the patient or which are placed over the area which we are scanning. Suppose say there is a coil for head, there is a coil for chest, there is a coil for your wrist or the knee joint. So these coils, what do? When energy is given through the RF coils. They impart this energy onto these hydrogen molecules to gain the energy and move into a different orientation. Once the RF coil energy is stopped giving, what happens? These hydrogen molecules try to come back to their position in the magnetic field. And when they're moving, spinning back into the magnetic alienation, they try to release energy, which is recorded by the RF coils again. These signals are captured digitally and then shown to us as an MRI image. Based on how frequently we are giving these pulses, how much time we are leaving between the pulse, and how the energy is being captured. Based on all these, there are different modalities of imaging which are being done. That is as I said, T1, T2, DWI, susceptibility weight images, all these things. So this is the basic method how an MRI is done. In this slide, I think you will be able to see, I'll try to, so in an MRI brain, these are the basic sequences which we usually follow. That is T1, T2, and a flare image. So T1 image here, the gray matter consists of all the neuronal cell bodies, appears more gray, and white matter, which contains the axons, which are arising out of the neurons, are all white in color. The CSF, which is a fluid, is usually black in color, and arteries are also black. I'll try to tell you why arteries are black. Whereas in T2, both gray matter and white matter are gray in color, but with varying levels of attenuation. Gray, lighter gray, CSF appears white in T2. This is the exact opposite of T1, and arteries appear black. A flare image is a T2 image, except that the CSF space, which is otherwise looking white, is turned to black for us to easily use the MRI image to visualize various structures. In all the sequences of MRI, most of the sequences of MRI, we see arteries black in color. The reason being, as we said, when we are put up in a magnetic field, hydrogen ions try to align, and the RF coil, when energy is given, the hydrogen ions spin, taking up the energy. What happens in arteries? There is movement of blood. There are no hydrogen ions which are taking the energy because they are traveling fast. So anywhere there is movement of blood, the energy what RF coils are giving is not being taken by these ions. So there won't release energy back for it to capture. So we will be seeing some areas without any signal coming. So these are called flow voids. Flow voids are the spaces from where there is no energy coming, especially the arteries. So pathologically, when there is no flow in the artery, so the artery starts showing some signal, which is bright. So in an MRI, in most of the sequences of MRI, when we see arterial spaces or the blood vessels bright, that is a pathology that there is no blood flow. So these, as I said, are the basic imaging model, T1, T2, and flare. So there are advanced modalities which have come up, which have helped in identifying the more physiological changes happening in the brain. They are diffusion wave image. So diffusion wave imaging, it detects Brownian movement of water. As you all are pharmacists, I suppose you all understand easily what Brownian movement is. This is random movement of particles within the tissue, the water molecules within the tissue. When a part of the brain parenchyma is affected by lack of blood supply, what happens? The water movement reduces. So this is being captured by this diffusion wave imaging. There is a diffusion coefficient which we apply over the T2 image, through which how much of uh, diffusion of the magnetic rays are being restricted. So with that, we get to see a more anoxic tissue or more ischemic tissue, more brighter on diffusion restriction, or we call diffusion restriction present. When I show you image, you'll get a clear understanding. So this is a patient who was presented to us within 6 hours of onset of a stroke. So what are we expecting in a brain parenchymal imaging? So the first image, which is a flare image, The arrow here is pointing to an area which is looking hyper intense. So hyper intensity on flare image means there is ischemic changes. Now this ischemic change, is it acute or subacute or chronic? We'll get to identify when we look at a diffusion wide image. So in diffusion wide image, if you note here the second and third images, the B value is the diffusion coefficient. So here you can see this is the area of interest, which is appearing more brighter than the rest of the tissue. As the diffusion coefficient is being increased, the ischemic tissue looks more brighter than the rest of the area. So this means there is an acute ischemia happening there. To quantify this, there is something called apparent diffusion coefficient imaging, which is nothing but the infarcted area or the areas which are showing diffusion restriction show black attenuation on ADC, and this can be quantified. So this is the other imaging modality which is of use in acute stroke imaging. So why are all these necessary for us? Because if you have a patient who is present to you in acute stroke, are these candidates for thrombolysis? When somebody coming within window period, and if CT brain is not showing any new ischemic changes or no hypodensities on CT, then MRI imaging modality will show you ischemic areas even before changes start to arise on a CT. So from this, we can identify early ischemic changes and take a decision on thrombolysis. This is another example who has presented within 1 hour of presentation. Patient has gone unresponsive and he has left-sided weakness and also has some cranial nerve deficits. First CT was normal, and then when we did an MRI, the MR flare imaging also was grossly normal. Because he had cranial deficits and hemiplegia, what we thought was could be a posterior circulation stroke. But when the flare is also not shown in image, then next we looked at the diffusion wide image. You can see as the diffusion coefficient was increasing, you can see here there is an area of hyperintensity on diffusion restriction image, suggesting a pontine or a medullary infarct. So this is suggestive of a medullary infarct. And you can see correspondingly the area on ADC is little dark in color on the right side. So this is what I was saying, that MRIs pick up very early ischemic changes. So in this case, the necessity for thrombolysis has been, decision to thrombolyze has been taken. The next imaging modality, which also helps in acute stroke, is something called susceptibility wide imaging. Here, what is being looked at is the contrast between the tissues. When there is blood or blood products in the parenchyma, we can detect that by using susceptibility wide image. As we all know, the best modality to capture a bleed is CT, not an MRI. But when we choose MRI to identify very early ischemic changes, our decision to thrombolyze, we should be confidently also ruling out a bleed anywhere for any reason. So in such case, having a look at susceptibility wide image will tell us if there is any bleed anywhere else, especially in patients with old strokes or chronic hypertensives where BP is uncontrolled. They tend to have multiple microbleeds. I'll try to show you an image for that. So here, when you see the right image, which is a CT, which is CT is showing only a hypodensity in the right parietal region. But when you see at the same patient's MRI, you'll be seeing multiple areas of black dots which are not seen on our CT. These are all called microbleeds. So in susceptibility white image, what we are seeing are blood or blood products where the hemosiderin deposits is being captured as a black thing on the MRI image. So this is called a susceptibility image. It helps us in identifying blood or blood products, broken down blood products. So as we said, MRI roles in acute stroke. So what are the common changes we see in an acute stroke? We see a hyperintense signal in brain on a DWI or a flare image. We see loss of gray matter, white matter differentiation. I think on this image, we all have seen. On the opposite side, you can see gray matter and white matter differentiation, but here we see there is lost. We see loss of sulcal spaces because of the edema. We see loss of arterial flow voids when there is occlusion or there is no blood flow in the vessels, we see the normal flow voids which we expect are not seen. And sometimes in some sequences like gradient echo imaging or susceptibility wide imaging, we might be able to identify thrombus as well. So here is an image, which is an MRI. Here we are able to see the blood vessel. The arrow is trying to point at the blood vessel, which is looking bright. That means there is loss of flow void, suggesting there could be a arterial thrombus. This is a susceptibility wide image. And here you will be able to see something known as sequence on susceptibility wide called blooming, where within the blood vessel space, this is the place where we identify middle cerebral artery. And here we are able to see some black structure within the blood vessel. Here, ideally, here we identify blood vessels in a white way, but here it is black. So this is called as blooming and indicates there is a thrombus within the blood vessel. This is an ADC image which is showing an infarct. Next modality is MR angiography. Over the last 8-9 years, after newer trials have come, like MR clean trial and all, there is for those patients who come within time window period, apart from thrombolysis, if there is an large vessel obstruction like the carotids or the middle cerebral artery, internal carotid artery, middle cerebral artery up to its M1 segment, there is a scope that revascularization can be attempted by doing an interventional thrombectomy. So to know that, if you are doing a CT, you may not be able to identify what's happening in the vessels. So then you'll have to do a contrast image again. But while in an MRI, at the same time, doing a DWI, along with it, you will be also able to see the vessels by looking at the MR angiography, and it will show you if there are large vessel occlusions. So how MR angiography works, as I said, this is a time of flight sequence. Based on time of flight sequence, the flow voids are usually shown up white in color for us. The image on the right is the raw image or the source image. And using images from this, a 3D reconstruction is done to show how the vessels look on 3D reconstruction. You can see the internal carotid arteries arising and entering the brain and then giving rise to the middle cerebral arteries on either side. Posteriorly, we see both the vertebral arteries joining to form basilar artery, and within the brain, all these structures trying to form a anastomosis called circle of Willis, from where all the blood supply to the brain happens. It helps in diagnosis, as I said, in vascular pathologies, in identifying arterial dissection, venous thrombosis, all these things. And as I said, low flow is what is captured like a thrombus. So when I said there is no flow, same time when there is slow flow as well, it magnifies the defect. So we can improve the accuracy of angiography on MR by doing a contrast enhanced angiography, wherein like a CT scan, we give intravenous contrast and then acquire an image where it magnifies or it increases the accuracy of MR angiography. Next imaging modality is the MR perfusion in acute stroke. As I said, we have dealt with patients who come within time window by thrombolysis, and we have dealt with patients who are requiring thrombolysis and who have large vessel occlusions to undergo thrombectomy. There are a subset of patients who come with us where the real time window is unknown when they wake up with stroke or they reach to the hospital 7 hours or 8 hours later. Here, now the trials have been supportive that revascularization of the ischemic area can be attempted up to 24 hours. But for that, you need to choose the right patient. How do you choose? We need to see how much of the ischemic area is core. Core means there is irreversible injury. And how much of the ischemic area is in the penumbral zone or area which has compromised blood flow. But if blood flow is restored, there is a chance that we can salvage the brain tissue. So we need to try to map how much of the ischemic area is the core, how much is penumbra. So what we require is perfusion imaging. So in a CT scan, we can do perfusion imaging by giving contrast and doing. The same way to do a perfusion imaging or an MRI, there are two techniques. One is through doing an IV contrast, where a bolus is tracked by doing multiple sequences multiple times and see how the contrast is flowing through the ischemic area and the non-ischemic on the opposite side of the normal area. And we try to compare how much cerebral blood volume is in the brain in the both ischemic area and the non-ischemic area. How much time is the blood taking to travel through that? Based on all this, we try to understand which area is permanently lost and which area still there is a chance that we can salvage it. Similarly, there is something called arterial spin labeling. This is a novel technique where without contrast, without administering contrast, we can try to do a perfusion imaging. Here, as I said, by assessing, trying to assess the cerebral blood volume within a given brain parenchyma and trying to assume the mean transit time taken for the blood to traverse through these areas, we try to identify core area and penumbral area. I'll explain you through some images so that you can easily understand. So this is an elderly patient who came to us with a wake-up stroke. And very early, the first CT was not showing much, but patient they had dense right hemiplegia. When we did an MRI and when we did diffusion imaging, what we could see was there are few areas of diffusion restriction. For these small, tiny areas, patient was densely hemiplegic. So because that was a wake-up stroke and we could not find the timeline, we could not decide on the time whether we need to thrombolize or not. These corresponding areas were black on the ADC, apparent diffusion coefficient mapping. So these are definitely areas of acute ischemia. So we took a decision that we did a imaging of the blood vessels where we could see there is a cutoff of the left middle cerebral artery. You can see here there is a cutoff of the left middle cerebral artery. So this ideally would be a case if we have to consider revascularization, we can do a intervention and try to remove the thrombus. So next is, so to take the decision, we need to identify, though the in fact diffusion restriction is showing only a small area, if we are not doing, is it that the whole area is going to be affected? So that we'll get to know by doing the perfusion image. So in this perfusion image, you can see the normal side of the brain and the opposite side. So in the opposite side, the one in the center in the dark area is the area which is the core. But the rest, all of this area is the penumbral region. So this indicates that if you are unable to re-establish the blood supply, this whole area is going to get lost. So based on this decision, we take our call that revascularization is essential here. And this particular patient has undergone thrombolysis because there were some challenges for intervention at the time. And then post thrombolysis, with 2 days later, when we did an image, we could see the diffusion restriction restricting only to these particular areas. And the whole area which we showed is at the risk of danger of getting infarcted has been saved. So perfusion helps you in choosing patient for the newer revascularization modalities. Can be done through CT or an MRI. And in MRI, if you use the arterial spin labeling technique, we can avoid usage of contrast to get the image done. The next common thing in ICU is identifying a hemorrhagic stroke. So this sequence, this is a recent patient who presented to us with right-handed numbness, paresthesias, and right upper limb weakness. When we did they came within 1.5 hours after the symptom onset, and what we identified was there was a, so the first, this is a flare image. The second one is a T1 image, and the third is a SWI image. As I said, when you have a suspicious lesion, which is looking hyper intense on a flare image, and which is iso intense or which is looking iso or hypo intense on a T1 image, we suspect blood. And we confirm that by looking at susceptibility weight image, where blood or blood products are shown darker in color. So with this, we could identify that there is a bleed. As I said, CT is the best modality to identify bleed, but when thinking somebody presenting within 1.5 hour, thinking of an ischemic stroke and MRI is done, we should not miss a bleed. So here SWI has helped us in identifying intracerebral hemorrhage. The other challenge in using MRI to identify blood is based on the age of the blood, the findings on MRI change. So this table roughly depicts what's happening. So as the bleeding happened, initially we have oxyhemoglobin, then deoxy, then methemoglobin, then blood products, hemochromes or hemosiderin. So based on these things, the images, how they appear change, how they look on T1 and T2 based on their age, less than 24 hours, 1 to 3 days, beyond 3 days, beyond 7 days, how they appear change. So this is one challenge where identifying a bleed and try to determine the age of the bleed requires some technical expertise. So still CT is the best model to identify bleed, but then if you have to tightly mark the age of the bleed, MRI definitely helps us. The other common place where MRI helps us is to identify the type of edema that we are seeing in this patient. This patient here on the first image is a cytotoxic edema, usually happens with ischemia. The second one, which is usually a vasogenic edema, usually happens when there is breach in the blood-brain barrier. This can happen around the tumors, around infectious areas where the blood-brain barrier is broken. We identify vasogenic edema. So how do you differentiate? The cytotoxic edema is predominantly affecting the neuronal cells, or predominantly affecting the gray matter. But in vasogenic edema, you see extensive white matter involvement more compared to the gray matter. So what it shows you like a finger-like pattern, which will help you in identifying a white matter edema suggestive of a vasogenic edema. Treatment is different, like hyperosmolar therapies definitely help in cytotoxic edemas, and in vasogenic edema, your attempts to curtail the inflammation by usage of steroids and all will help in vasogenic edema. There is a third type of edema called interstitial edema, which I didn't focus much, but usually happens with hydrocephalus with raised ICP, where there is seepage of the CSF into the parenchymal interstitium, where you see hyperintensity extending around the ventricles, like you see around the hilum in pulmonary edema, interstitial edema arising in a brain with hydrocephalus, where the ICP or the intraventricular CSF pressure goes up. There is ventricular seepage into the brain parenchyma from the ventricles. It will cause interstitial edema. So I think this is pertaining to MRI which I've taken. There are more modalities if people are interested, like where in neurodegenerative diseases, based on the areas which are involved. So somebody coming with tremor, rigidity, slowing, memory loss, we need to identify whether it is Parkinson's or Parkinson's plus, because the modalities of treatment vary. There can be frontotemporal dementias, FTDs. There could be Lewy body diseases. There could be PSPs where there is more brainstem deterioration. In all such cases, treatment drug choices can be different. MRIs also help in identifying if there are any pathological lesions, especially in patients presenting with seizures or status epilepticus. If a lesionectomy can help in management of these patients. So basic understanding of MRI, how images are acquired, what pathology is happening in the brain parenchyma, and how do they show us in the images, and choosing what drugs like thrombolysis or intervention, or as I said, your hyperosmolar therapy, or it is anti-inflammatory therapy. Or as I said, if you are entering interstitially dominantly, then CSF drainage. So MRI helps you in all these things. And I think this basic understanding is a must for all of you who are attending an ICU with more neuro patients. Thank you.
Thank you, sir. I think sir described everything very detailed, like the pathophysiology, the imaging. As a clinical pharmacist, how we can take a clear decision making after seeing these images. How we have to interpret different kind of imagings, how it looks in infection or in acute or chronic conditions. So and what are the drugs causing the lung injuries. So I would like to extend my heartfelt gratitude to sir for delivering such an insightful and enriching section on MRI brain and CT chest. We truly appreciate the time and efforts to share the knowledge with us today. And I also want to thank all the participants for your active engagement and throughout the session. We look forward to many more such informative discussions in the coming sessions. Once again, thank you, sir. We sincerely appreciate your time. Wishing everyone a great day ahead. Thank you.